Welcome back, everybody. Chris, how's your first week, August?
First week of August is going well. Getting back to some normalcy after my mom left. Mimi and I celebrated our 13th anniversary. So, quick aside, I got completely foiled. I was up at the local store with Kai, and I went up there to get some balloons, helium balloons that have a 1 and a 3, and then a happy
Mm-hmm.
anniversary balloon. And of course, Mimi comes strolling into the store, and she's looking at me like, "What are you
Why
up
are
to?"
you here?
So, yeah. So,
Nice.
but yeah, it's good. It's a nice time of the year where, sort of enjoying summer. People are, I feel like they start to unplug a little bit. But how are things in KC?
Yeah, same. Just getting ready for the kids to go back to school. So enjoying a little bit of the end of the summer, and then we'll be happy when my kids are back with their buddies on a normalish schedule. So, but yeah, it's all been good. It's about it. Similar to you, there's kind of waves of busyness in my business. I think in yours too, and so trying to keep it a little bit more tame until for the next couple weeks, and then stuff will likely pick up again. So, but it's been good.
Yeah, cool.
So today's topic is going to be how to argue against physicians and win. So we're gonna we're gonna talk about disagreeing opinions and how to handle that with healthcare providers. A lot of times, at least in my experience, when I talk to other PTs, there can sometimes be some contention if there's different views in how to handle a patient situation between maybe a physician and the PT or whoever's running the rehab side of the things, Cairo, ATC, whoever. And so we're talking about that, and then kind of those instances where you do have to maybe step in and put your foot down a little bit more, and if it's in your patient's best interest. So we'll go through a couple of cases that we've both worked with. I have a couple that I want to start with. So when we're dealing with bone stress injuries, I've talked about this a bunch. We can put them in lower high risk buckets, and
Hmm.
depending on which one we think someone fits in really can change our management. Most of my patients come in directly to me first. I will get some physician referrals, but often that is after I send them to a physician. Most of the time I'm the entry point into the healthcare system for a runner that's dealing with pain. And so they come in, and I'm suspecting that they might have a tibial bone stress injury, or they might have a femoral neck bone stress injury based off of their exam and their history. And my advice is going to differ depending on which one of those situations that they end up in. And there's research on this. There's a great paper by Stu Warden that we've talked about a bunch of times on management of low risk bone stress injuries. The thought is if someone comes in and they are exhibiting symptoms of a low risk injury or they've been diagnosed with one, we can generally have them do a lot more. So
Hmm.
I can think of a patient example of someone that came in a few months ago. They had been diagnosed with a tibial bone stress injury. It was a stress reaction, so there wasn't a fracture line present, and they were advised to take 12 weeks off of all activity. So this was recent. This wasn't 15 years ago. And so that is a situation where I feel like if we're dealing with someone, really if we're dealing with anybody, but certainly if we're dealing with someone that's active, I probably have to push back against this a little bit because unless there is some other unforeseen variable that I don't know about, they can probably be doing more. And if you take a runner out of all activity for 3 months, that's going to be a long road back. So to me,
For sure.
that is one of those situations where you can say, this doesn't really match my understanding of the literature, how I typically manage these. Here's kind of my thoughts on how we should handle this. And then that can be very different than if someone comes in with a high risk bone stress injury. So I know in the past you've dealt with some navicular bone stress injuries, I believe, that have connected with you first. Um,
Mhm.
how do you handle a situation like that, especially if maybe they're getting different advice than what you kind of understand is the best approach with those injuries?
Yeah, I'll unpack that momentarily. If we stick with the theme that you just brought up or that case, how did you handle that? So, obviously the doc said no activity for 12 weeks. We know that's really a recipe for trouble and prolonging someone's recovery. Did you just continue to advise a patient or without getting the doc involved, or did you engage the doc and say, "Hey, I'm consulting this person, they had communicated to me that you said 12 weeks of no activity, and I just want to better understand your thought process." or how did you broach that?
Sure. So this is one of those instances where they came to me second. I should have clarified that at the start. So basically, they had developed the injury, had seen someone, and then reached out to schedule with me after they had been not non-weight bearing, but not doing anything. They were advised to not do any kind of exercise. So they arrived to the clinic having not done anything for 12 weeks. So
Mm-hmm.
there's two different ways I think that I can. So if they were referred to me right off the bat, let's say I saw them 3 months prior and I had sent them off and they had
Mm-hmm.
gotten diagnosed and then the physician had said, okay, 12 weeks. That is an instance where I do have to call or email or try to figure out what's the reasoning for that. Is there some other health consideration? And it is something where I might have to push back a little bit with the physician. And we all have different relationships with different doctors. There's some docs that would be a really easy conversation for me to have because I have a closer relationship with them. If it's somebody that I don't know, and this happens to me a lot, you might have this too, where someone's been given advice by someone that is, I don't know them, I don't know, there's no relationship there. The likelihood that they're going to even listen to me is really low. And so that's an instance where I tend to come back on the research and talk about that more with the patient. When I've been in situations like this previously, where I'm trying to understand why we are being so conservative with a situation that doesn't seem to be needing quite a conservative approach, it normally gets shut off. So like for me to say, hey, have you read the Warden paper from 2021 that said da 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 da? That's probably not going to go over well with a doc that you don't have a relationship with. If it was someone that I knew, I can text them and say, hey, like, I just want to understand, kind of your thought process here. Are you okay with them to do X, Y, and Z? And so however that relationship is set up is really important. But if it's not somebody that you have a relationship with, there are times I think where you do have to kind of set your foot down a little bit if you're still in that window. Now, this person arrived to my door 3 months deconditioned, if we're being honest. And so
Yeah.
at that point, I don't know that it's helpful to the patient for me to even really acknowledge, hey, it seems like it's kind of been botched right off the bat. It's more to say, hey, you've been off for a long period of time. If we measure your calf girth, there's a 3 centimeter difference left versus right. And, we are going to have to take a fairly long approach to getting you back just to make sure that, we're putting you in a situation for success. And so I think a lot of times in these instances, it depends on the relationship and how open someone is to receiving your feedback or questioning. And then in those instances, which is more in the high risk cases, there are times where you kind of have to say, look, what this person is advising you is kind of against the consensus on this injury. And so I just want to make sure that you're have an understanding of what the research tells us with this. And, as you're making decisions along the way.
Yeah, those are always fun conversations when you have to engage a doc who, probably, I can't think of many docs that would have your working knowledge of this, Nathan. So, but it also, you have to avoid getting into, sort of flexing, right? Because
100%.
ultimately we want to make sure that we look after the patient. Like, let's not let egos get in the mix. It's like, how do we do well by the patient? And I think, unfortunately, that's what gets lost a lot of the times, because you do want to showcase this knowledge. And I think we've sort of been at the beck and call of physicians. That's sort of like the history of our profession. Fortunately, we have direct access in most states where we're autonomous providers, where we can speak candidly. Obviously, we need to know a lot of times, and I think you would echo this, it's much more work if a patient has already seen a physician and then they get sent to us, because we have to take the time
100%.
to say, hey, what's been communicated to you about your situation? Because I don't want to step on toes. I want to make sure that we're sending similar messaging, so long as it's accurate and it's what the patient needs to hear. But all too often, we know the reality is the opposite, where they've been told a bunch of bullshit. And, the person who originally consulted them, whether it's a physician or someone else, didn't really take the time to ask the critical questions and to really get a global picture of this athlete. And then they're advising them. It's like, that's sort of the stage is set for trouble. But
yeah, I think I run into that.
It's like,
I run
ahead.
into that in two different situations. Yeah, you're good. The first one is around when I can run and when I should expect to kind of be back to normal with bone stress injuries. tendons to a point too, but someone is told like, hey, here's the launch date. Here's when you can start. You'll be back to running in X amount of weeks or X amount of months. And I think that is a very easy number to almost like pull up an algorithm and say, you'll be running in 12 weeks, 10 weeks, whatever. But in reality, the return to run progression and return to competition, which is what most of my patients are really looking for, is when can I race again? That's those are two very different situations. And the timeline between those two can be quite long. And so even if you can run at 8 weeks, I think people are kind of, and then you're medically cleared, right? You're going to be cleared by the physician. That messaging sometimes has to be pulled back by the rehab provider. And for you and I, this is, one of the unique things that we do is we tend to be with people for a longer period of time. And so, if I'm talking to someone that's 7 months out of off of a diagnosis of a high risk injury, they're probably not racing, at the level that they want to. It's probably 9, 12 months, 18 months. And so trying to pull back some of the hope that they got from the idea that they would be running so quickly can be challenging. And so, and that's not even necessarily misinformation or bad advice from the physician. It's just there's a lack of clarity, I think, in that information. And so that is something that I think we often have to contend with for anybody that works with people for an extended period of time. If all I did was consults, all I did was eval people, my job would be really easy and my outcomes would be really good because I would see them once and I would never see them again. I don't really know what it's going to play like out down the road. And I think at times the PT or the person that's guiding the rehab, you have such a longer time period with the person where maybe the initial thoughts that they're given from someone that's not quite the whole situation.
Yeah, and I think the point you made about being cleared to run versus being back to racing are very different things. And I think that's where there's a lot of confusion. And this is why that article by Claire Ardain and colleagues in BJSM is so important because, it's saying, hey, when we say, you're cleared to run, it's like that means you're returning to participation. That does not mean you're plugging back into a 30 to 45 minute run. The reality is it means you're plugging back into a 1 minute run, a 4 to 5 minute walk, right? And I'm also always fascinated, and I pose this question to patients. They said, hey, I was cleared to run. And in my mind, I'm thinking, oh, well, that's convenient. And I said, that's great. I'm excited that, you got a favorable report. Can you tell me what that decision was based off of? I'm assuming that they, the doc took you through some tests or assessments to make that decision. Can you tell me how that appointment went? And they're like, oh no, they just cleared me to run. I'm like,
right.
Pull up a seat.
Yeah.
So,
yeah.
But that distinction, you're back to participation, where you're slowly starting to do the activity in a very graded manner where you're definitely still a patient versus return to sport where you're starting to sort of plug into a normal, training week and then, racing. I always say you rehab. I'm going to botch this. I haven't used this saying for a while. Yeah, let me come back to it so I don't screw it up. So
yeah, and I think in those situations you're trying to have a kind of a unified front with your patient.
Yes.
It's super easy to be siloed with all this stuff, and often athletes are having more than one voice in their head. It's the rehab person, the physician, the coach, or whoever. You're trying to come together in those situations, and those are situations that I would say, they're not high risk. I think there's situations that are high risk, which we can touch on in a little bit. But, the differences between allowing someone to exercise with a low risk bone stress injury that's pain free, and someone that's been advised, hey, keep pushing through pain with a high risk bone stress injury. Like those are two very different, or like someone that is forced to take medication or running after a cortisone injection or, some of the other really big red flags that we see. Those are different situations to me where I do feel like there's times you kind of have to put your foot down and at times even sever relationships with referral sources. Now, again, because of most of our patients are direct access, I understand some PT's apprehension if they're at a clinic that has 30 physicians and people that they have to kind of appease to, or maybe they're in a hospital system where there's a hierarchy to these decisions. Like it's a different type of situation, but still there are instances with runners where you do have to kind of say, look, I'm going to say it as nice as I can, but this is bad advice right now. maybe I would figure out a nicer way to say that in the moment, but it's bad advice, and I'm worried that it's going to put you in a bad situation in the long run.
Yeah, and I think, that phrasing is really important. So to circle back, it's rehab to train, train to compete, compete to redefine your limits.
Yeah.
So, but yeah, the phrasing of what we were just discussing is really important to say, hey, look, this is really, how you're approaching this process really flies in the face of what we know on the topic through all of the peer-reviewed literature. But I think how you channel that messaging is really important. But like you said, ideally, you want this to be a unified front. And that's why it's critical that if someone is consulting other providers, that you really know what's being communicated to the so because if there's any sense of doubt or conflicting information, that's just basically going to be picked up by the patient, and it's going to basically lead to anxiety or fear or doubt in the program that they're following.
Yeah, absolutely. So how do you handle, so you have some examples of maybe situations where, again, it's a little bit more high risk if we don't manage this appropriately at the start. Do you want to touch on some of those? I know that you've talked about a couple different cases with a navicular that you've seen where you've maybe had to push back against advice that someone has been given.
Yeah, I've gotten a bunch of calls in recent months from people scattered across the country and even world, which puts you and I have to deal with this a lot because we're not licensed in some of these states, most of the states. Mm-hmm. So, I'm always trying to at least triage and get this person in the hands of a skilled rehab professional and or orthopedist, if that's what the situation calls for. So, like you just said, sometimes you just need to be very blunt and say your son or daughter should absolutely not be weight bearing. The research is clear on this stuff. Mm-hmm. So I had a great case recently where, a very sweet nurse connected with me who is pretty sensible. She started for the first time in her running career, and she's been running for over a decade. She started introducing some interval work, which she had never previously done. And she was prepping for a half marathon. She's a nurse. She works long shifts a few days a week. And it was textbook in terms of her pain diagram on her intake form. It was right over the end spot. And she presented, and I'm like, this doesn't make sense. She had pain at the top of, when doing a calf raise, and she also did some single leg hopping, and it was just guarded. And I just said, let's just stop here. I want to send you off to get imaging. And I sent her to a doc who's very well respected, someone who I know and trust. And he said, hey, he ended up consulting the woman. He was able to get her in short notice, which is really important in these cases. And he said, yeah, I don't really think that this is a navicular bone stress injury. Maybe it's an ankle sprain, or she sustained some kind of sprain. I'm thinking that doesn't make any sense from a clinical reasoning standpoint. Like when did the sprain occur? She would have recalled that. She's never twisted her ankle. She has no remarkable past medical history for an ankle sprain. And, but he said, I'll get an MR just to be safe. Sure enough, the MR comes back and implicates a navicular, and it was a low-grade bone stress injury. And I told this woman when we wrapped up that initial consultation, I said, hey, I'm not really the person you need to see right now, but I do want to prepare you for this because other people may give you a different message, but you're going to probably need to go non-weight bearing for 6 weeks. Like that's pretty clear in the research if someone presents with a navicular bone stress injury. She gets the MR, it confirms a navicular bone stress injury, and the doc says, we're going to have you go non-weight bearing, cam walker, weight bearing for 4 to 6 weeks. And I'm thinking, oh shit, this isn't going to go well. Yeah. And, I messaged him, I said, I had prepared her, for the fact that she's going to be non-weight bearing. So, hopefully this goes to plan. And, because he publishes on this stuff. It's not like he's out in left field. And yeah. I got a message 6 weeks later saying, hey, I got out of the boot and I tried to walk for a day and, the pain is still present. And now the doc wants me to go non-weight bearing for 6 weeks. I'm like, for fuck's sake. I'm like, can we just stick with my plan moving forward? Because you and I know, all of the papers on this show you that weight bearing, and I've seen this three different instances where someone has been given the green light to continue weight bearing, but put in a cam walker. And 3 of those people are done running. They're like, yeah, I don't really run anymore. And I'm like, oh, that didn't need to be the case. So
Yeah.
That's a situation where I think the doc, if he didn't get the memo after that, and the problem is it's a patient whose recovery gets prolonged. I don't care whether hopefully the doc had some learnings and took the time to reflect on that case, but that's where it's frustrating, where someone gets tangled up in the medical system. So
Yeah. Yeah, I would agree. I think those are the instances though where you're concerned with the person's health, overall health and well-being or longevity with running, that it is necessary to put your foot down, even if that is maybe going to hurt the relationship with the physician. And even if the patient doesn't take your advice. We've talked about this so many times. We can't make our patients do anything. All we can really do is say, hey, here's our perspective on your situation. Here's what the literature says. Here's my advice. Here's what, could happen if you take a different approach to this. And in those situations, it's like, well, you could be done running, you could need surgery, you could, whatever it is, those other kind of outcomes. But at the end of the day, people are going to choose to do what they want to do. But they do, I think for us, we have to inform them of those risks. And in those rare circumstances, that means we might have to be kind of like, here's how we have to manage this, or I don't think that we're going to be a good fit to work together. That stuff doesn't happen that often, but it does happen every once in a while. And so you got to do that because people aren't always going to listen to your advice.
Yeah, I think this stuff we always talk about the importance of communication. And I think around bone stress injuries, if we stick with that theme, it is just so doggone important.
Mm-hmm.
And I always, if it's a low risk site, I don't always shuttle people off for imaging unless there's other factors where I'm really concerned, or they're just someone who wants concrete evidence, like do they or do they not have a bone stress injury? And even then,
I'll say
the Bergman
that to people all the
study,
time.
we have to be careful of how we interpret that.
Yeah. So I'll tell that to people, like, if you need to know, then you can certainly get the MRI. And some runners are like that, where they say, I just need to see it. I just need to see that it's there, see that it's not there in those low risk instances, which I'm fine with. But I always follow it up with that. This is the same thing I do with any patient. If they're going to get imaging, and how that might be interpreted is, look, here's what we know. Lots of runners have low-grade stress reactions that aren't painful, asymptomatic meniscal tears, all the things that we know, muscle tears, all those kind of things. And so to me, it's like your pain and your presentation has to match your imaging. I think I remember first reading that described in the Weiberg paper on symptomatic FAI, where like you need the clinical presentation, the imaging, and pain to confirm that you have it. And that's the same thing with lots of different things. If I'm referring someone out that feels like they really need an MRI for their knee pain, I'll tell them, you might have a small meniscal tear. If it's in your hip, you might have a small labral tear. Just remember, those things can happen a lot. Sometimes they need surgery. It's normally if it's in these certain instances, like a traumatic event or a significant loss of range of motion. But I don't want you to assume just because you see it that that's going to have to change for you to have a successful outcome. Sometimes, you had a post on this a couple of days ago, I think, like sometimes you need surgery. Sometimes you need an injection. There are situations where those are necessary. Conservative care is not the right approach for some people. But there's lots of times where the people will receive that information from a radiologist or from a doc, and there'll be no context provided to it. And for us, you want to make sure that your patient has a good understanding of the situation. And sometimes that means prepping them for that even before they get the image or they meet with their physician again.
Yeah. I think that, the advantage that we have as rehab professionals too is we have more time to spend with patients, and we get into much more nuanced conversations, and we start uncovering things that, and this is something I don't fault docs for, and I should preface all of this by saying, like, I am the product of or being trained by orthopedic surgeons, so there in any field, there are good people and bad people. And, this is not to knock docs, but, you also have to keep in mind, like that stat from the Curry paper, which is basically 63% of docs. And this is out of, I think, 131 physicians that were surveyed. 63% didn't even know what the female athlete triad was, right?
That's a good study.
65% of those docs were attendings. So, this is why it's important to read the literature, but, above that, to understand certain questions that you have to ask, because if you don't ask them, you're not going to paint an accurate picture. And I think of a wild case where, I'm consulting a young gifted runner. I think he's entering his senior year, and he had a snowboarding accident. The doc, ended up getting imaging after he was having ongoing unilateral low back pain, and they're like, oh, turns out that you have a sacral, fracture from the snowboarding fall. And I'm like, I've never seen a kid with a sacral fracture from a snowboarding fall. And I've been around like sort of extreme sports my whole life. And I'm like, this sounds more like perhaps there's some compromised bone qualities. And it was that fall that really sort of exposed the problem. And he ended up consulting a couple docs, Seattle Children's here. But yeah, I mean, that was a sacral BSI that I think was being treated as an acute fracture. That simply wasn't the case. And you're barking up the wrong tree. You're not going to make the right referrals, and you're really going to put together a suboptimal plan of care in that kid's case. And, the frustrating thing about that is that he consulted a doc, and I hadn't had a chance to speak with the doc beforehand. And the doc's like, oh, yeah, like we can get you running in 2 weeks. And I'm like, well, wait a second. I've been following this kid for basically 3 months. You swoop in and you're all of a sudden making all these recommendations. And he has a kid's best intentions in mind. But I sent him an email because he said after the kid had his first follow-up, he said, oh, they mentioned that you're not going to clear them for another like 4 to 6 weeks, and that sort of was in contradiction to what he had relayed. And I sent him a very long message, and I said, hey, here's my understanding of the kid's situation. And by the way, did he also tell you that he's slated to go to a cross-country camp in a couple weeks? He's like, no, I didn't know any of that. I'm like, that's my point. I have a lot more information that I'm making these decisions with.
Yeah, and this isn't to paint physicians in a bad light. Like you said, like they're super qualified to handle many, many things. I think that I was talking with a PT that both you and I know that's out in the Boston area a couple days ago about this. When people connect with a physician, one of us, maybe they connect with someone that mainly does research. They work with maybe this demographic in different ways. There's pluses and minuses to all of that. So if you go see a physician for a one-off consult, they have a unique perspective on someone's situation. They're going to be much better at, referring out for certain tests, for interpreting imaging. Like that is they go to medical school. That's a whole other set of things. There are people that mainly produce research, and they are great at producing really helpful research and viewing that in a very broad perspective. And then there's people like you and I that we tend to work with people for a long period of time. And I think that all three of those situations are very, 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 very different. And the benefit of, like you had said, of the way that we work together is you tend to get a much broader and maybe more realistic perspective on someone's situation because you have more time to do that. And you can kind of zoom out and say, okay, here's my understanding of the small number of things that you and I work with and this person's situation, what the research says and my experience with this, and seeing how all of that kind of plays out with this individual. That's a very different situation. And I think it's really, really hard now for consumers and for even like young clinicians because they're inundated with so much information. I think that process of meeting and evaluating someone and spending a lot of time with them over a course of care while having some foundational knowledge, that takes a long time to attain. And you and I still mess up. Like I still have patients that I flare up and I still miss stuff and all of those things. But I think that it's really the stuff that the rehab people tend to do, whether you're an ATC or you're a chiro or you're a PT, if that's the way that you work with a distance runner, especially one that has a bone stress injury, it's going to take a long time. That's just such a different situation than I think what often seems like a case study on a board exam or just like these little snippets. And it's like, oh yeah, just get them doing bone loading programs or just, have them fill out the REDS Cat 2. Like, do those things probably. But how you do that with an actual person is different to me. And that's one of the unique perspectives that we get to have.
Yeah, and I think the physicians who, I've always worked well with, I don't tell them how to operate. And they would just say, hey, this is a non-surgical case. I want you to go and see Chris or whoever. I mean, when I was at NISMAT, they'd just say, you're in their world. calling us if they'll reach out if they need any information from us. But I think that's a very powerful message to the patient to say, you're in the best of hands. This is a non-surgical situation, fortunately. So my role here, sort of becomes not an afterthought, but it's not what you need at this point. So.
Mm-hmm.
But yeah, the communication piece, and this is why if you connect with docs and you have good rapport, that you want to really, nurture those relationships, because, I know that when, again, back to New York, when I was around orthopedic surgeons every day, when you can lock arms and have very consistent messaging to the patient, the outcomes are better. It reduces anxiety. People aren't left to their thoughts to the same extent versus if you have people giving conflicting information. And there shouldn't be a lot of variability in what we're recommending for people, especially with running related injuries, because we know the performance demands, and
Right.
all too often, runners are just chomping at the bit, and they want to run because they're restless, not because they're ready, right? And that's what we want to avoid, is like to make sure they're ready, to make sure I always keep the reins on people longer than they think or what's been communicated to them, because what's the harm? Unless they're a pro athlete and their sponsorships are in jeopardy, like, don't rush the process. It's a chance to just really make sure that you've done due diligence, and then when they set sail, be conservative.
Yeah, if you hold back someone a little longer in the early stages, that has no effect on what they're going to be doing 9-12 months down the road. But unless we screw it up and we get them doing too much, and trying to get them to avoid distractions. When you talk about messaging, there's a thing that I call the square of seduction. So this is the things that runners will get seduced by with bone stress injuries. And that's ultrasound, shockwave, lower body positive pressure treadmills, and BFR. I think all those 4 things are very easy to be enticed by. They might provide the smallest of benefits, but can very easily become big distractions. And so, going back to people getting advice from someone, if they're told, oh yeah, like, you got to just, BFR is going to solve all your problems, or we got to get you doing these shockwave sessions, and I know they hurt, but they're really going to help. And, we got to get you fixated on running in the Ultra G or the lever system, or, whatever boost treadmill, whatever you have access to. It's like, those are the smallest of priorities. They're very easy to get seduced by them. But there's probably a much more straightforward approach to your situation. But sometimes that's what they'll get sold on, whether that's from another rehab person or their coach or the physician or whoever.
Yeah, it makes me think. I had a woman who had reached out regarding a case, and she's like, oh, I have this runner who's late 20s, I think 29 years old. And in the message that she originally reached out with, she said, this is a single mom who's a nurse that works 4 10-hour shifts, and she's a runner and has a history of an eating disorder. And she's like, she's having this vague anterior hip pain. I'm like, femoral neck bone stress injury or something brewing.
Yeah.
She'll prove otherwise. And she's like, you're so quick to say that. Why? I'm like, because I've seen this pattern like countless times. And she has basically some like weird stiffness in the hip flexion, as well as just passive range of motion, not where it's like the patient's jumping off the table, but she's like, just the patient reports some stiffness. It's not as fluid on the other side. And she got the MR. She underwent an MR yesterday, and turns out she has, what do you know, a compressive side femoral neck bone stress injury. And her question was, so can we do any non-weight bearing lower body exercises? I'm like, nope. Yeah, and this is when like people want to do stuff, and I'm like, no, this is a one instance where you actually do nothing. And it's going to be so challenging for your patient because they're going to get restless, but you just can't screw around with these. So, and I don't know what the physician even communicated. And I think this brings up a really important point where I think I made this mistake early in my career, and fortunately I didn't get any pushback. But remember, you're not the person who ordered the image. Correct me if I'm wrong, but like legally, it's the doc who goes over. I let the doc go over those findings. With that said, I want to get a copy of the MR. I want the patient to take screenshots if they can, and then I want the radiology report. And what happens? Everyone's like, "Hey, do you want me to send you the CD?" I'm like,
no.
What decade are you living in? I don't even have a CD player or reader.
Yeah, I
But
don't either.
being very careful not to start disclosing your interpretation of the imaging, because that's not, in most states, in our wheelhouse as a PT. So
Yeah.
again, it just gets back to like, hey, what's been communicated to you? Did the doc go over the MR results yet before you start basically spilling the beans, right?
Right. Yeah, I don't. I'm happy to go through the radiology report because we're basically okay. What is that? What does that mean? What does that mean? Because that's what the patients want to know, and normally they don't get clarification on that. So I'm happy to do those things, but yeah, I'm not gonna tell you. I think this is what you have. If I happen to get the actual pictures before your doc does, I might take a guess at it. But again, it's like know the stuff that you don't want me reading your imaging because I'm not licensed to do that. I'm not qualified to do that. I can interpret, I can talk about your radiology report and what it says, because I do think that can have a lot of helpful information for how we manage someone's situation, but I'm not trying to do more than I'm licensed to do.
The one thing that really cracks me is when someone is having, hip pain or unilateral low back pain. And this is an instance where you want to take a hard stand where, maybe that patient's been offered a diagnostic injection to see like, hey, how does this affect your situation before that doc even has a working diagnosis.
Yeah, I've had patients like that.
That's
It
where I'm
seems a
like,
little
hey,
iffy.
well,
I
what happens if
just
you have
get
a
an
bone
MRI,
stress
please.
injury? Yeah.
Yeah,
Yeah. It's
please
like,
just get an
if
MRI.
you have a bone stress injury brewing, or even if you have a tendinopathy, like you're just creating a strike against a person, and that could go on
Yeah,
to a much more grave or sinister situation. So,
yeah. Yeah, cool.
any other
Well, hopefully
final
everybody found
thoughts,
this episode
comments?
helpful. I don't think so. Oh, we have a course coming up. We should talk about that.
Oh, yeah, New York.
We're gonna be we're gonna be in
Yeah.
New York this fall. Do you want to fill them in on the location?
Yeah, so we're going to be at Motion Physical Therapy, which is in Midtown. I think it's East 57th Street, but that's going to be October 4th, 5th, which is just an incredible time. Having lived in New York City for 11 years, that's one of my favorite times of the year. If you're interested, would love to have you join us. We're clinicians, we're in the trenches with people, and we love to show you how we navigate a lot of this stuff, because oftentimes it's very messy. So, and
Yep.
like you said earlier, we don't always get things right, but we've had, I would say, enough success where we can start to say, hey, here's how you want to think about navigating this situation. So it's very, very clinically oriented, and obviously it'll be approved for CEUs. So yeah, I'm looking forward to it, and hope to have you join us. And if you have any questions, reach out to us.
Yeah, and there'll be a link in the show notes to sign up and learn more. And like Chris said, if you got questions, feel free to shoot us a message. Happy to chat. But otherwise, hope everybody has a good rest of your day.
And I just want to sort of leave people with one final thought is, I think that when you are around a tricky situation involving a patient, always lean into these conversations, right? So if you're a little bit trepidatious, or maybe even nervous because you feel like you want to engage an orthopedic surgeon who may be, sort of like from a hierarchical standpoint, you're just nervous because you don't want to question their decision making. Lean in, tell them your thought process, and
Mm-hmm.
I think in hindsight they'll really respect that. Towards the end of my time when I was in New York City, if someone had a rotator cuff repair or insert any surgery, I would just ask the doc. I would say, hey, how confident are you in your work? And they would say, hey, crappy tissue, like we need to be conservative, like I got in there and looked a little bit different than what I had expected. Or they would say, hey, green light, like feel free to push this person a little bit.
Mm-hmm.
I think we tiptoe around this stuff too much, and I think we need to have candid conversations with docs, and for there not to be any hierarchy. That's a bunch of bullshit, right? So
Yeah, I agree with
we're
you.
here to help the patient who's consulting us, and these conversations never need to be heated. It's never you're questioning someone's judgment, and if they interpret it as such, and you explain things in sort of a mild manner, and it's obvious that you've done due diligence and that ruffles their feathers, that's on them, right? And that may be
Yeah,
an
anything
indication,
would
hey,
ruffle
this
their
is just
feathers.
someone that you want to steer clear of. Yeah, and you're not aligned, or maybe they were just having a bad day and you give them the benefit of the doubt. But
Yeah.
I feel like a lot of people get reputations, especially orthopedists, but the ones that I worked with were always very conservative.
Mm-hmm.
they were even conservative around. They would never even prescribe meds. It'd be like, oh, if you want to take some anti-inflammatories, like just go to the local pharmacy and you can take 600 milligrams 3 times a day with food. But even then, they bet on the body. And,
Yeah.
that was a really powerful experience when I was in New York to be around that. So, but that's also why they were world-class docs. Money wasn't the driving force of their decision making. It wasn't,
No.
I mean, obviously we live in a capitalist society, but they really just wanted to do good by the patient. I remember Dr. Nicholas, when I had this clavicle fracture, I'm like, this thing, it looked like it was just such a hot mess. The two ends were very displaced. And he came in, he pushed on a little bit, he looked at the x-ray, and he's like, I wouldn't operate. I'm like, what? All of his partners are like, I'd fix this in a heartbeat. And he's like, Chris, all you do is ride your bike. You're, early 30s. Like, if anyone's going to heal, it's you. And yeah, it may look a
Yeah.
little bit different, and it's going to take a little bit longer, and he was right. And I had surgery on my second clavicle fracture on the other side. And what happened, the doc put a plate in that overhung the AC joint, and I ended up having to get it removed. And I'm like I should have trusted, the conservative route in this instance. So in any case, well, hopefully this helps everyone. Hope you enjoyed the this particular podcast. And other than that, we hope to see you in NYC.
Yep. Thanks for tuning in.